Well, welcome back. I hope you had a nice lunch. Those of you who aren't experiencing the world's worst allergy season had a few minutes to go outside and experience the loveliness of the West Campus this time of year as all the flowers are blooming and stuff. But now we go back to business, and it is indeed a pleasure for me to introduce our next speaker. Dr. Marie Bakitas received her ADN and RN and BSN from the University of Bridgeport, her MS from the Boston University, a postmaster's certificate as an adult nurse practitioner from the University of New Hampshire, and a DNSC from here at Yale. And she completed a postdoctoral fellowship here in 2006 to 2008. So this is the first person who, and I specifically asked Marie as a representative of our doctoral program, and I was so glad that she was able to join us this afternoon. She's nationally certified as an adult nurse practitioner, advanced certified hospice and palliative care nurse, and an advanced oncology certified nurse. Prior to her recent move to the University of Alabama, she was an associate professor in the Department of Medicine, section of palliative medicine at the Geisel School of Medicine at Dartmouth. I always want to give his other name, but it's, yeah. Seuss School of Medicine, and in the Dartmouth Institute of Health Policy and Clinical Practice. While in her position there, she also served as a visiting scholar at Boston College School of Nursing, as well as a clinical professor here at Yale. Dr. Bakitas is an internationally recognized scholar whose content expertise focuses on the principles and concepts of hematology and oncology, bone marrow stem cell transplantation, pain and symptom management, palliative care, and novel qualitative and mixed methods research. I mean, that's an entire portfolio of research residing in one person. Excuse me. Through her sustained program of scholarship, she is focused on conducting innovative pain and symptom management and palliative care interventions to improve quality of life and care for people with serious life-limiting illness and their families through improved management of distressing, not depressing, physical symptoms. That could be depressing. She has served as principal investigator on 12 funded research grants, and currently she has an R01 funded from the National Institute of Nursing Research for a palliative care randomized clinical intervention trial, and has additional funding for 2 companion grants. The goal of this current project is to determine the effectiveness of a telephone-based palliative care intervention for rural cancer patients and caregivers, continuing our theme of the underserved, now not inner city, but rural. Marie is a fellow of the American Academy of Nursing and has received prestigious awards from the Oncology Nursing Society, the Council for the Advancement of Nursing Science, and the Cancer and Leukemia Group B, among many others. She demonstrates a sustained commitment to interdisciplinary collaboration and in teaching didactic and clinical content. She will be speaking on establishing a research base in palliative care at the end of the beginning. Marie, welcome back.
Thank you. And I'm going on record that I get 5 extra minutes.
No, I count from now.
You count from now? Oh, no. I'm in deep trouble. Well, I just wanted to say that I was extremely honored, and I kind of read the email a couple of times when I was invited to come here. And my fiance, who's sitting in the back here, pointed out when he looked at the program, he said, you know, those people have been doing this a lot longer than you. You're the youngest one graduate here. So I wanted to just echo how much of an honor it is to be able to come and talk about my research, something that I'm extremely passionate about, and even though I am a late bloomer. And so the title really speaks to the fact that palliative care, being one of the newest sort of specialty fields, has really made a great deal of progress, and we really are not at the beginning any longer, and we need to make that next step. So I wanted to start out by just showing a picture of some of my many mentors, 50% of whom were from here, and some in the little box that you can't read. And it's because of them that I am standing here today. So I wanted to just make that acknowledgement. It takes a village, right? And so what I'm going to talk about in a very brief period of time is a series of nurse-led studies that have really followed the evolution and set the evidence base for where we are now in this field that we call palliative care. And so in terms of the milestones, Yale nurses actually were foundational in the field of palliative care, beginning with Florence Wald, who really brought the concept of hospice to this country and was the motivating person behind the development of the first hospice in the United States. There were other things that were important in the 70s, but I think in the United States that was one of the most important developments. In the 80s, really the idea of that we are getting older, and HIV was prominent. In addition to that was the passage of the Medicare hospice benefit. So again, sort of another benchmark and milestone that led to palliative care. In the 90s, again, we revisited the idea ethically of self-determination with the Nancy Cruzan case, the Self-Determination Act, where we were allowed to then, we were allowed to know that we had the right to refuse treatments if we wanted to. And Dr. Kevorkian had his own way of dealing with end-of-life care. Fortunately, he was convicted of murder and placed in jail. But I think one of the things that was in the development of palliative care for the field, as well as for my own development in this area, was a landmark study called the Support Study in 1995, which showed really the tragedy of what end-of-life care was looking like. And by chance, Dr. Joan Tino and Joanne Lynn, who were prominent co-investigators of the Support Study, happened to be at Dartmouth. And even though Dartmouth was not one of the support institutions in the 5 that are mentioned here, which were showing that patients were dying, people were dying in severe pain, they were conscious, they were aware, they were distressed, they were having difficulty tolerating these symptoms, so this was sort of a national scandal of end-of-life care, they said, well, in God we trust, all others need data, and so they challenged us, where we thought we were doing such a great job in end-of-life care at Dartmouth, and that this was just happening elsewhere, to do our own little chart review study, which ended up getting published in the Archives of Internal Medicine. And a study like this would never be published today because, you know, it was just this little chart review study. It was called Death in the Hospital. And what we found was that of the 50% of people in the consecutive deaths that we reviewed, 50% were cancer patients, the people that we thought we were doing such a great job with. More than half of them had problems with shortness of breath, pain, anxiety, etc. And so that we really couldn't stand there and say, well, you know, that's everywhere else that this is happening. We're really doing a great job. One of the other important findings was that about 40% of the people had advanced directives, but they were still undergoing treatments like, as you can see in the slide here, half of them were still getting weighed, half of them were still getting blood samples, and these data are collected in looking at the last 48 hours of life. I always tell my students or my other co-professionals, if you ever weigh me in the last 48 hours of my life, I will definitely come back and haunt you. There's no question about it. Similarly, patients that had what is a very big stretch to call them explicit goals of care if you have a do not resuscitate or comfort measures only order, had statistically less of many of these procedures. And so it started to make us think that, well, maybe if we had a plan and we identified people were actually dying, that the types of interventions that are inappropriate for imminently dying patients would not be happening. Another major learning was that the psychosocial support, which is considered standard care today, less than a quarter of patients in the last 48 hours of life or their family members, or predominantly their family members, were getting these services. So for us, a kind of a light bulb went on. If you were in the hospital, dying was prohibited. So the problem of improving end-of-life care, we could have sort of turned and said, okay, we need to do a better job of pain management, shortness of breath, and we needed to do that too. But maybe the bigger issue is you keep people out of the hospital in the first place. And so this was our good cancer early detection and prevention strategy of approach to end-of-life care. And so what that resulted in was this approach, which was not a new approach, but the World Health Organization recommended this idea of concurrent care from the beginning of a new diagnosis of a serious illness. And so this is the World Health Organization model. Believe it or not, this is the original picture from 1990. So back in 1990, the World Health Organization was telling us that the current model of care where we do this cure, cure, cure treatment, make this terrible choice, jump into palliative care, and usually this box looks like it could be a long period of time, but it was typically about 1 week before death. Palliative care delivered by hospice was kind of happening here, and they said no. Really, at the time of a new diagnosis, the services that palliative care has to offer are of benefit even at the time of new diagnosis, and over time, as disease progresses, that those services should increase and those life-sustaining treatment types of services would diminish in number. So the problem with the WHO model was that this was just sort of intuition, and there really was no evidence base. And so what we did for the next, beginning in 1997 with our study, that was a demonstration project funded by the Robert Wood Johnson Foundation promoting excellence in end-of-life care, was we went about trying to test that idea that palliative care offered at the time of new diagnosis could have an impact at the end of life. So that was the very, very simple premise behind this work. So this was 4 cancer centers were funded. Out of the 23 funded RWJ programs, 4 of them were cancer centers. We were one of them. I'm in right there, the little red circle. We had these every 6-month meetings of all of the projects that were funded by RWJ. And I think one of the nice things to realize is RWJ funded the $12 million support study that showed the poor end-of-life care, and then as a result of that came back and said, we want to figure out how to do something about it, and they funded the Promoting Excellence 23 demonstration projects. And basically they said, we know hospice does a good job at the end of life. See if you can bring those hospice principles earlier in the trajectory. And so that's what we did. It was called Project Enable, and Enable stands for Educate, Nurture, Advise Before Life Ends. A very simple idea. Several glasses of wine ended up coming up with that. We determined that the only way you get funded is have an acronym, so now we had one, and we got funded this time. And the idea was that to determine a feasible model to introduce hospice and palliative care principles at the time of a new diagnosis of advanced cancer, as recommended by the World Health Organization. One of the problems with end-of-life care and demonstrating is that the typical endpoints in clinical trials are survival, right? Mortality. And in this case, you know everyone is going to die. So how is it that you determine the end-of-life care that you did was in any way, causing an improvement? And what were you improving? So this is my very favorite cartoon. Could I trouble you folks to fill out this questionnaire rating my performance? And so at the pearly gates, we could stand there with our clipboard, right? But of course, this was a little unrealistic. And so one of the things that was methodologically important was how do we measure whether we're doing well or whether this treatment is having any benefit for patients. And so in terms of the demonstration project, the first study, Enable 1, we didn't know it was Enable 1 at the time, but it happens that it was. We were able to demonstrate that we could do it. Because people said, you can't go into a cancer center where they're coming for cure and these new drugs and these new treatments and offer them palliative care at the same time of diagnosis. And so what we were able to do with 380 people, was enroll them in this demonstration project, and this stands for Concurrent Oncology Palliative Care, and show that of those participants, 268 of them died. We were able to interview proxies because we couldn't stand at the pearly gates with our clipboards. And I'll show you that data in just a second. But the goal of the first project was really to test out our instruments to see what was it that we could gather for data. And we did some just basic satisfaction questionnaires, et cetera, with patients and caregivers. Our program was called Charting Your Course, and I was talking to Lois earlier because there's actually, you can take a lot of what Lois said this morning and put it into what Charting Your Course is in terms of prevention, avoiding trauma, preparation, this reflective. There's a lot of those elements actually in Charting Your Course program, which was what we were offering. We did this almost, in fact, I remember going to visit the childbirth educators. It's like, how do you get these, how do you identify, people, women who are pregnant, and then get them to come every whatever for your courses, because we wanted to kind of do the same thing. And so we learned, sort of how they went about identifying people, and we tried to apply that in our project, and that's how we ended up identifying people. But it was really very childbirth kind of focused. And so we used the idea that when you're pregnant, you don't wait until you are 8 months and 29 days before you say, maybe I should think about what's going to happen after I have this baby. And so we decided the premise of this was that we really needed to early on, when people were newly diagnosed, give them the tools and the skills that they needed to be able to get through this other very important life event. From the proxies in Enable 1, what we were able to discover was that using the tools that we had, and again, because this was not a randomized trial, but compared to local and national benchmark, we were able to demonstrate through proxy report improved clinician and communication at the end of life, decreased rates of hospital and nursing home deaths, and increased rates of advanced directives, home deaths, and hospice involvement. This particular graph is just one of the hospices that was local to our area, and they were able to show, and again, we could not demonstrate cause-effect here in any stretch of the imagination, but it was interesting to note that the number of patients, the average daily census, and the admissions to the program had increased over the 3 years of our project. But again, this needed to be confirmed with an RCT. So, time to get serious. What this means is that, as Ada Sue had mentioned earlier this morning, many of us were doing this research with master's degrees. And I was one of those people, which is why I'm the late bloomer in some respects. But it was at the end of the demonstration project that Ruth McCorkle and Tish finally worked at me and worked at me and worked at me, and I came back. Because I used to tell people, I didn't need a PhD. I already had one. His name was Tim, who you saw on one of the first slides, was my mentor, and I was very happy to be the clinical partner paired with the researcher. But now it was time to kind of say, okay, that was not his area of focus, and this is what I needed to do, and you really needed, a doctorate to do that. So this, Tim was the PI on our RCT, and because, although I call the name of the study Improving Palliative Care for Patients with Cancer and Their Caregivers, you'll notice this was funded by the NCI, and so we did not call it palliative care. This is probably the only palliative care RCT that was ever funded by the NCI, but we had called it Improving Supportive Care for Patients with Cancer. And as I said, we used this childbirth model, and of all of the advantages of it, we were bringing people in for classes, right? We found out in Enable 1, if you are, sick, near the end of life, fatigued, and 2 hours over a mountain in a snowstorm, you were not coming for classes, even no matter how beneficial they were. And so we ended up doing probably about 50 to 2/3 of our education and coaching by phone. So a light bulb went on and said, well, maybe we should just do it by phone, right? We should have some in person, but really do the bulk of it by phone. And so that was the major difference between Enable 1 and Enable 2 was we converted this to a phone-based intervention, and again, it was nurse-led. And here's what I'm talking about. So in terms of the environment, for those of you who are not, this is where Tish's place is up here, right? And I don't know in Vermont where the rest of you are, but this is New Hampshire and this is Vermont. And these dark purple splotches with circles in them that you can't see are indications of where patients were from that we were managing telephonically. And this is our intervention in our control group. So you can see that we had quite a spread of where patients were coming from. And this is indicative of where people come from to go to the cancer center at Dartmouth. And many of you know, if you've ever tried to go, this is where Dartmouth is located right there. East to west, you can't do it in any period of time, right? And then if it's a snowstorm, you're not going up and down 91 either. So did we accomplish our goal of treating newly diagnosed patients? And so here you can see that more than 80% of people were getting chemotherapy at the time of enrollment. So yes, we were getting people at the time of diagnosis. This is the usual care group, and this is the intervention group. And you can see on all characteristics, they were similar. This Karnofsky performance status of almost 80 is really very functional, ambulatory people up and about. And our results, again, we found that this was the functional assessment of chronic illness therapy, palliative care. In cancer clinical trials, the FACT tool is a very common treatment tool that looks at quality of life. And there was one that had been adapted for people with palliative care concerns, so this was our quality of life tool. And this is the scores here, and then our baseline assessments, and the number of people that make up that particular data point. And what we were able to demonstrate to a statistically significant result was that people who were in the intervention group had statistically higher quality of life. And in the interest of time, I'm sharing just our two sort of major findings, though there were many other positive findings. And in terms of the CESD for depression scale, and I'm sure that many of you know that 16 is the cutoff of clinical depression, those in the intervention group had lower depression scores, and those in the usual care group, and this is, again, of people who died. The others were of all patients. These are data from patients who died that towards the end of life, many of them had scores in the clinical depression range. So the other important thing that wasn't something that we thought of, because of course in clinical trials what you're looking at is primarily survival, and what we were able to show was that there was not statistically significant, but very clinically significant, almost a 5.5-month survival advantage if you were in the intervention group versus the control group. And probably the reason that we did not show statistical significance was primarily an issue of power. So we were not powering to look at survival, and however, we definitely showed a survival advantage, even if it was not statistically different. And this was published in JAMA. It was published on a Thursday. It was the lead article, and it was the same day in August that in the debates about the Affordable Care Act, there were protesters out in front saying that we were killing Granny because of the idea that there would be funded counseling for people about treatments, life-sustaining treatments, and end-of-life care. And so on the opposite page was our paper that showed, our study that showed that counseling of this kind actually improved quality of life, reduced depression, and improved survival. And because the legislators couldn't hang in there with that, it got yanked, and that was the end of our study as well, in terms of the publicity. Because prior to that, we'd been in USA Today and Associated Press, and things were just getting rolling. I'm not bitter that happened, but so what we concluded on this from ENABLE-2 was that concurrent oncology palliative care improved quality of life and mood, that further study was needed to show improvements in symptom intensity, and we actually showed improved but not statistically better symptom intensity in the intervention group, and that concerns about palliative care shortening survival were certainly unfounded, though we couldn't say from a statistical standpoint that survival was improved. Being the good quantitative and qualitative mixed methods researcher that I learned to be at Yale, thanks to Tish and others, what we did was look at patients' perspectives on participating in this RCT and what the benefits and burdens were. Because try to get some of these studies through your IRB, right? And particularly where you're trying to do measures and the burden of those measures is something that is often questioned. And in fact, what we found from our patients, and there were 53 alive who consented to be interviewed at the end of our study, was that they did like what we were teaching in the intervention in terms of coaching, and they actually liked the questionnaires. I'll just read this, so first of all, just one quote from the themes of what participation in the study was like. It's a supportive mechanism because, for example, when the nurse and I would talk on the phone, she knew what was going on with me. It wasn't like I had to explain everything, so that was very supportive. So this was from one of our intervention lung patients. And then in terms of, we asked about the trial procedures, I felt in some way like somebody was hearing my individual situation. It was interesting to fill out. It was sort of like, instead of keeping a diary, how has your last week actually been? Well, it's sort of nice to sit down and think about it. So again, this has been very important work to be able to cite as we go through the IRBs. And they're saying, can people fill out, and do they want to fill out all these questionnaires? So just in case you need a citation, there you go. The other thing we did was we asked the oncologists. So there were 33 oncologists, hematologists at Dartmouth and at the VA, because this was a multi-site study, who referred patients to our trial. And so we were able to show that the oncologists believe that palliative care should be involved, my favorite quote, early and often, that the care approach, their care approach was very different for advanced stage patients versus early stage patients, and that they saw partnering with palliative care is in a variety of ways, using us as consultants or co-managers, but that it was really hard to tell the timing. That the timing was an issue, and actually the patients indicated that timing was an issue. Some of them said, well, this would be good for some people, but I'm not really symptomatic, and so maybe I could see where it would be good for somebody and maybe for me later on. And so this timing question kept coming up as a theme. In the interest of time, I'm not going to show you, well, all right, so I'll show you one quote. In this model, what we're showing is the themes related to oncologist provision of palliative care and palliative care, how they use palliative care. And so they saw themselves really as treating the whole patient, and that they would really call palliative care to assist them when the palliative care they were providing was, it was beyond their skills. And again, my favorite quote of one of our thoracic oncologists, she said, "When do I refer early and often? Our approach from the get-go has been that these patients have an incurable illness, and we have to take care of the whole person, which involves palliative and supportive care with or without chemotherapy." And that was, just completely made my day and my life, honestly, to have an oncologist say, everyone gets palliative care, and you could also have chemo. So we're trying to get that language into other oncologists. So at this point, again, in 2000, where are we at with palliative care? So we realized as professional organizations we needed to get involved with policy. And so the palliative care professional organizations that are listed there started to really shift their activity to, we need more researchers. Clinical care, we're making some improvements, but we also need to make some improvements in policy. And so you can see here a number of the issues that have come to be. I was very proud that the American Society of Clinical Oncology published this provisional statement based on 7 RCTs, of which ours was one to state that combined standard oncology care and palliative care should be considered early in the course of illness for any patient with metastatic cancer or high symptom burden, and the latter not being necessarily people who have incurable disease. And so our study was it was so happy to have B as my first name because we were listed first in alphabetical order. It was great. Our study was also part of a Cochrane review that looked at the effectiveness of home-based services in improving home death. So this is where we are now. Enable 3, which is an NINR-funded study where we were trying to look at the question of timing. And the model, which I can speak to more if people have questions of sort of how this works, the major important addition to that WHO model is that primary care, really, when you're dealing with people in rural environments, is at the foundation of all of being able to provide good palliative care. So this was our design. We called it a fast-track design. Some people called it earlier versus later. We called it earlier versus earlier palliative care because at the time of diagnosis or 12 weeks later, which was our design. So we collected data. The immediate group started their main part of the intervention, and then the delayed group had usual care and then started the intervention 12 weeks later, which again, for many, was still quite early in the progress, and then we collected questionnaires. And these were the outcome measures that we have collected in the last study. The picture of ASCO is on this. Please don't take notes and tell any of the press about this because we're embargoed until the 30th of May when we present this data. We randomized 207 patients, is all that slide tells you. But once again, we accomplished getting people at the time of diagnosis when they were still getting their anti-cancer treatment. At baseline, we had similar results, but the most important thing I wanted to point out here was the CESD, which again is that depression measure, was a full 2 to 3 points higher at diagnosis than with the Enable 2 group. So I'm not sure exactly what that means, but in terms of early versus later, we have some small to medium effect sizes. We have no statistical differences between starting early versus later on any of our main outcome measures. However, and also in resource use, though 6 days of hospitalization over a 14-month cancer diagnosis is still incredibly low compared to national standards, though there was no difference in the immediate versus delayed groups in those parameters. Location of death, however, almost 50%, which is a complete flip from what it used to be, and most of the rest of the country, people died at home as opposed to hospital, and once again we see this survival advantage. So this time we have a statistically improved survival in the first 12 months relative to the group that was delayed. So something about immediately starting the intervention has, okay. No, okay, great. I was going to say, really, Margaret? Sorry. So in conclusion, our outcomes for the Enable 3 trial are that although the immediate versus the delayed patients experience a significant survival advantage at 1 year, the longitudinal patient-reported outcomes were no difference between the two. And we really need to look at mechanisms, and we have built in mediator and moderator analyses, as well as biomarker analyses that we'll be doing after we get through getting these in. However, the really good news is that our caregivers, which we actually added an intervention for caregivers that was separate in their own, did show a statistical difference between the in depression, stress burden, and higher quality of life with medium to large effect sizes. So this is the result that the ASCO group will be putting in their media program. So again, our biggest challenge at this point is to test this intervention in minorities and low SES, though many of our rural patients, 60% of the patients were in a rural area. In all of our studies, there was really no minorities or any real ethnic diversity, racial diversity in these groups. So that's kind of where we're going next. So I think that I will stop there except to say that really the evidence is out. Now practice needs to follow suit. And that's basically where we're at. At this point, we have an American Cancer Society funded dissemination implementation science study in 4 sites. We're trying to implement this in sites that have a high minority representation as well as in a veteran minority population. So that's my story, and I'm sticking with it. Questions?
Actually, I have a question.
Yes.
Can you speak at all to the use of palliative care measures for like non-cancer illnesses, like fibromyalgia or like rheumatoid arthritis, things that aren't necessarily terminal, but that do affect quality of life?
Believe it or not, heart failure is pretty darn terminal and actually worse in prognosis than many cancers. And I'm so happy that you asked that question. I didn't ask her to do that. So what we have done, Enable 4 is actually our implementation study, but we've completed 1 pilot and we're in the process of completing now a 2nd pilot in a minority population for patients with heart failure. So we have, for the last 2.5 years now, been adding in work looking at doing concurrent care with people who are diagnosed with an advanced heart failure disease. And we're looking at in older adults over 65. And in our current National Palliative Care Research Center 2-site study, we're doing it in Birmingham and up at Dartmouth so that we can start to integrate early on the minority population. And I just wanted to sort of pick up on that point, besides my fun slide here, which Margaret will appreciate. So living on the borderline between your competence and your incompetence, if you always feel competent, you aren't doing your job. But what I wanted to point out was that, again, minority, if you look at this slide, you'll see that the South has the poorest penetration of palliative care in the United States. Less than half of the centers have something that they could call palliative care. And so I moved from here to here. And really what I'm doing now is to show you that the percent of cancer patients hospitalized during the last month of life among hospital referral regions. These Dartmouth Atlas maps are very easy to read. Light colors are good and dark colors are bad. And so I've moved from what now in New Hampshire and Vermont is a very low hospital death rate to here's Birmingham right here, which is nearly 50% of people with cancer dying in hospitals in the Medicare population. Yes?
In New Hampshire and Vermont have independent practice for nurse practitioners.
Correct.
They are probably more willing to order palliative care for their patients. The access to that benefit seems to be much easier. My father, who's going to be 102, was put on palliative care, and I had to find a physician to order that for him. And I think that one of the barriers, and hopefully we'll see that barrier lifted as the states roll out, will be allowing nurse practitioners, because they will be the ones who push for that benefit, I think, a little bit more. If you look at the South, it's going to be probably one of the last to go.
Yeah, it's definitely going to be the last to go. And you're right, New Hampshire and Vermont, and nurse practitioners can order palliative care consults. We are palliative care practitioners, in those states, and Mississippi and Alabama, not so much. So I think that there is some relationship there, but yeah, it's gonna be a while, and that's what I'm doing there. Yes.
Well, is there a minimum standard palliative care, or does the care itself, does it change depending upon the geographical location and the population? Or is there just one canned standard of the care?
Yeah, it's not one size fits all, and I think one of the reasons that we made progress here, because we did work with rural palliative care, is that we built it into algorithms, or there were triggers, or there were sort of automatic referrals, and we haven't been able to accomplish that. We're starting to do it there. So building it in, and what you do as the palliative care consultant will vary depending on where the person is in their illness. So somebody who's brand new is just thinking about decision-making, communication. Somebody who is farther along in illness is probably very much focused on symptom management as well as family coping, et cetera. So,
Yeah, you had talked earlier about the biomarkers. I wonder if you could share a little bit more about that.
I would love to. We collected salivary and plasma cortisol at 2 time points in a subset, as well as some cytokines and lymphocyte subsets. And we're going to be analyzing that data soon. So we were looking to see, is there an association between the patient-reported outcomes and the biological measures? And is that somehow the explanation for the survival advantage? Because I'm not sure how we're going to explain that in the second study, where the patient-reported outcomes were not different between the groups, even though there appears to have been a survival advantage again.
You have a couple more
Oh,
minutes.
okay, great.
Just a quick comment. I was glad to see your findings about some of your patients not minding to fill out the questionnaires, because that's been our experience too. I'm always worried about subject burden and not overwhelming people with all these questionnaires. And we've had many comments from our participants similarly that they actually like to fill them out, and it's given a chance to think about some of these things that otherwise they don't.
Right. And again, the big challenge there is what questionnaires are an intervention. I mean, many studies have shown that doing these questionnaires, and in our first 2 studies, we did them by pen and paper. We've made some progress in Enable 3. It's all phone-based, and so interviewers are collecting the data. So we actually are happier with the data in our Enable 3. But, I think that's the problem, is that people like the questionnaires, and they are in interventions, but there's no way around it.
Thank you.
You had any awareness of like the training for providers in palliative care? Is it something that's being brought in nursing schools or medical schools or both? Or do you have
Pretty much every medical school in the country now has some palliative care content being brought into it. It used to be like 5% of the textbooks had palliative care focus, and now and no content really in the actual coursework. But that's changed quite a bit, and so we just have to get those enthusiastic people and palliative care educated people out into practice. So it's coming. Thanks.